great pleasure in inviting Professor G. Balakrish Nair. He's the National Chair of the Rajiv Gandhi Center for Biotechnology, Trivandrum, India. And I also have great pleasure in saying that he's been my mentor for the last 3 years when he was at THSTI. He's has several awards to his name, including the prestigious Shanti Swarup Bhatnagar Award for Medical Sciences in 1998, 500 research papers, several book chapters, and has edited and co-edited several books. Dr. Nair, looking forward to your talk.
Thank you.
Dr. Nair will be talking on undernourished children and the gut microbiome.
Thank you very much, Dr. Sanjini Bhatnagar. My talk today would deal with undernourished children and the gut microbiome. Over the past few years, we have been working on malnutrition and gut microbiota of children living in low-resource settings. Just to get definitions in place, malnutrition is a term that usually is used to cover both undernutrition and overnutrition. Undernutrition is one of the major serious problems affecting global health. The Food and Agriculture Organization of the UN estimates that about 870 million people were undernourished in the 2010-2012 period, representing 12.5% population of these cases of the global population, and 852 were in low-resource developing countries. Again, what is undernutrition? Undernutrition is defined as the outcome of insufficient food intake and repeated infectious diseases. It includes being underweight for one's age, too short for one's age, what is stunting, and dangerously thin for one's height, which is wasted, and deficient in vitamins and minerals, which is micronutrient malnutrition. The onset and progression of undernutrition has been attributed to a variety of critical factors, and these are inadequate diet intake, which impairs immune responses, which then makes you susceptible to enteric infections, and which in turn alters microbiota and causes dysregulated gut permeability. Each of these factors could worsen and perpetuate each other as a result of impaired innate and adequate immune responses. Adaptive immune responses. This is just to give you a sense of how much prevalent this is. This slide will show you the percentage of children under age 5 who are moderately or severely stunted. Globally, more than 1/4, that's 26% of the children under 5 years of age are stunted or were stunted in 2011. Roughly 165 million children, and roughly 101 million children were underweight, and 52 million children were wasted. This burden is not evenly distributed as shown in this slide. It's spread over largely much of sub-Saharan Africa and South Asia. This slide again is quite an alarming one, shows the percentage of children under age 5 who are moderately or severely wasted. Moderate and severe wasting represents an acute form of undernutrition, and children who suffer from it face a markedly increased risk of death. The highest wasting prevalence is in South Asia, where approximately 1 in 6 children, 16%, is moderately or severely wasted. Look at India. The burden of wasting in India is highest, which has more than 25 million wasted children. This exceeds the combined burden of the next 9 high-burden countries. That's it, 25 million children. And that's one reason we took up this, and these studies attempting to find out what the association with gut microbiota is. Malnutrition, the vicious cycle of diarrhea and undernutrition in susceptible children is shown in this slide. This is influenced mainly by the environment, the human genome, host nutrition, and the human microbiome, of which we are going to talk today. Undernutrition has been associated with a range of long-term health effects, including stunting, recurrent infection, and cognitive impairment. So let's look at what the link between gut microbiota and undernutrition is. And for this, what I've done is that there has been a spate of very interesting studies in the recent past which have elegantly investigated the link between gut microbiota and undernutrition. And what I will do in the next few slides is to give you a snapshot of these work that has been done. The classical and the most cited one is the Malawian twin study, which went on to study the relationship between gut microbiota and kwashiorkor, which is an aggressive form of malnutrition, which is characterized by generalized edema, hepatic steatosis, skin rashes, ulceration, and anorexia. 317 twin pairs were monitored for 36 months. Of these, 50% were normal, 43% became concordant for some form of malnutrition, and 7% were discordant for severe acute malnutrition. So as soon as the infant were diagnosed with SAM, both siblings were given ready-to-use therapeutic food, which is peanut paste, sugar, vegetable, and fortified milk. From these 9 controlled pairs and 13 discordant pairs, shown here for kwashiorkor, were profiled for their gut microbiota. Healthy twins had considerably more differentiated gut microbiota than those with kwashiorkor. RUTF not only improved the patient's symptoms, but also had a major effect on the gut microbiota. No specific microbial signatures were found in relation to gut microbiota and kwashiorkor. And the authors related to possibly not a particular microorganism being related to this, but several sub-microbiotypes being involved in the complex disease of kwashiorkor. The microbiome of children with kwashiorkor failed to mature over time. This is a series of experiments shown in this particular half of the slide. The authors then went on to test the causal relationship between the gut microbiome and the host metabolism by colonizing germ-free mice with the microbiota from discordant twin pairs. Only mice with combination of kwashiorkor microbiota and Malawian diet, shown up here, showed a loss in weight. Mice were switched to RUTF, which was associated with rapid weight gain, particularly in the kwashiorkor group, as shown up here. But when they were returned to the Malawian diet, the numerous changes remained in the controlled microbiota mice, whereas the changes were not sustained in the kwashiorkor mice, showing very clearly the relationship between microbiota and the disease. Another very interesting study which has come out in the New England Journal of Medicine relating to malnutrition, microbiota, and antibiotics. This is another recently reported randomized controlled clinical trial including 2,767 Malawian children with kwashiorkor, marasmus or marasmic kwashiorkor, which is a more intense form of malnutrition, which investigated the effects of 1 week of oral amoxicillin, cefdinir, which is oral cephalosporin or placebo, in addition to RTUF. And to make a long story short, this important clinical trial concluded that addition of antibiotics to RUTF for uncomplicated SAM was associated with considerable improvement in recovery with mortality rates. They have gone in to try to explain what might have happened. These antibiotics may probably act against pathobionts, which are found especially in increasing numbers, as I'll show you in subsequent slides, in malnourished children. A Bangladeshi study also studied the relative abundance of the dominant bacterial phyla in the gut of healthy and malnourished children, and they did this in 7 healthy and 7 malnourished children. Their finding was that the OTUs, or the operational taxonomic units, were higher in healthy children as a gross. Malnourished children, in malnourished children, proteobacteria dominated over Bacteroides, and the percentage relative abundance was 46% to 18% respectively, which was converse in children in healthy children with Proteobacteria and Bacteroides relative abundance being just anticoincidental was 5% and 44%. And there was an increase of about 172-fold time in pathogenic genera like Klebsiella, and about 7-fold higher of Escherichia. These investigators concluded the predominance of potentially pathogenic proteobacteria and minimal level of Bacteroidetes as common cell microbiota might be associated with the ill health of malnourished children in Bangladesh. In India, we did this study. The Indian study involved studying the gut microbiomes of Indian children of varying nutritional status. These were 20 children, less than or equal to 60 months, were selected as study subjects from Birbhum district, a rural district in West Bengal. The children had no history of diarrhea, acute respiratory infection, or had any antibiotics for a period of 5 weeks before fecal samples were collected. We looked also at the nutritional status of these 20 children, and this was done by using, it was quantified by using the WHO recommended 3 nutritional Z-scores as shown in the slide. And in order to obtain an overall measure of nutritional status of children, we also calculated the cumulative nutritional index, which is the sum of the above 3 mentioned Z-scores, and we called it the cumulative nutritional index. And the 20 gut microbiomes were divided into 3 groups as apparently healthy, borderline malnourished, and severely malnourished. So all the data was subsequently correlated with either the cumulative Z-scores or preliminary with all the Z-scores individually, and then with the cumulative Z-scores. This is a bit of a complicated slide, but I'll try to go through it as slowly as possible. We studied the variation of microbial groups with nutritional status. If you look at this axis, is the metagenomes arranged in the bottom panel from left to right in decreasing order of the cumulative scores, that is this way. And the taxa are arranged vertically up here on the left panel as a hierarchical tree based on the similarities in the abundance patterns into G1, G2, G3, and G4. If you look at cumulative G4, with the decrease in nutritional status, you'll find that G4, that members comprising the G4 group started increasing. And the G4 group were mainly comprised of organisms from the Proteobacteria family, phyla. G2 and G3 did not seem to have any discernible effect, whereas G1, with the increase in nutritional status, these also started decreasing. And G1 were mostly the beneficial common cell flora. So there seemed to be a distinct pattern up here. With the decline in nutritional status, there's an increase in Proteobacteria, or the G4 group, and with the decrease in nutritional status, there's a decrease in beneficial bacteria. To further look into that, we looked at several genera belonging to group G4 members, namely Escherichia, Streptococcus, and Shigella, and these were observed to be significantly overabundant in the severely malnourished categories as compared to apparently healthy category. Further, along individual genera belonging to the genus G1, did not belong to any of the significant differences across the three groups. The combined abundance that is shown up here of the genera, which is the group G1, belonging to this group, was observed to be significantly higher in the apparently healthy category. We also went on to look at the network of co-occurring genera for three nutritional status, which meant that we were looking at individual microorganisms. We also started looking at their co-occurrence. And in the apparently healthy, despite having contrasting trends in abundance, some of them showed strong positive association amongst each other, which was quite puzzling to us, like Streptococcus and Faecalibacterium. You had a beneficial bacteria and a potential pathobiont being linked to each other, but interpret it like this as a pressure being exerted by the beneficial bacteria to maybe suppress the pathobiont. Now, as nutritional status decreases, generally the pathobionts or the proteobacterial potential pathogens come in together in a single connected hub. And at the severely malnourished children, the increasing interdependence among the genera even become more pronounced, with all the pathobionts coming together as a network and probably forming a threat to the nutritional to the diseased child. We also profiled the abundance of different functional categories in the gut microbiota, and this study revealed that certain functional categories are positively and negatively correlated with nutritional status. And those that were positively correlated were functional groups that were associated with nutrient uptake and better utilization of nutrients, whereas the ones marked, the red bars, are those which are functional groups associated with virulence. And finally, we also looked at the casezyme families, or the carbohydrate enzymes. And a key finding in this study was identification of three groups of carbohydrate active families with the nutritional status of the children. These groups were observed to be dominated by casezymes families that preferentially degrade peptidoglycans and complex plant carbohydrates. These were mainly group 3, group 6, and group 7, as shown in this heat map. Finally, this seems to be the best way or model to model the interaction between gut microbiota and diet in the context of undernutrition. And this can be modeled like a topographic map shown up here. Diet and gut microbiota are two independent parameters that are critical for an individual's health, which is determined by the metabolic status shown here by this red dot. A healthy situation is obtained when the metabolic status moves around the optimal metabolic space, which is this part up here. So the more an individual drifts from this optimum, the more he tends towards disease. Although other factors admittedly can be critical, the interaction between diet and gut microbiota needs to be considered in addition to dietary intervention alone. So have a look here. If you have the metabolic status going just by diet intervention in a germ-free situation, then you see the metabolic status drifting like this. In fact, not going to the optimal metabolic space. Whereas if you have an interaction between diet and microbiota, it beautifully moves into the optimal metabolic space. So the key messages, and very quickly, is that, of course, a clear link between intestinal microbiota and SAM has been established. Nutrition is associated with lower diversity. Severe malnutrition was associated with more prolonged delay in gut microbiota maturation that was only partially corrected by food interventions. Antibiotic therapy might modify the microbiota and affect the potential for energy extraction. and the gut microbiota, this is important, under nutritional deprivation conditions, appear to develop towards a disease-promoting microbiota. So that's about the studies. So at the end of it, we asked ourselves, can probiotics and prebiotics improve therapeutic outcomes for undernourished children? And went into literature and looked at this meta-analysis of 74 randomized placebo-controlled studies, which sought to study the efficacy of probiotics in treating 8 distinct gastrointestinal diseases. Overall, there was a benefit of probiotic treatment, though there was wide variation in effect size. But importantly, these prevented repeated episodes of diarrhea, which contributes to undernutrition, and that is something which sounds good for treatment in malnutrition. And therefore, probiotics can be used to improve the nutritional status of malnourished children, at least we think theoretically from this meta-analysis. There's also a Cochrane review which studied 63 randomized and quasi-randomized placebo-controlled trials comprised of 814 participants. The trial showed a reduction in diarrhea duration following probiotic treatment, despite much variation in effect sizes. And the effect sizes may be because of inter-individual variation in human gut. So when designing nutritional interventions for malnourished individuals, it's important to select specific strategies for the cohort being targeted. There have been studies involving Indian children where specific probiotics can significantly reduce, or have been shown to significantly reduce, the duration of diarrhea, the occurrence of diarrhea, and significantly increase weight and height. The success of these studies raises the possibility of using probiotics. And finally, let me come to this workshop recommendation, which was conducted by the International Scientific Association of Probiotics and Prebiotics. This was a workshop conducted in Cork, in Ireland, from October 1st to 3rd, 2012, and they came out with these following 4 recommendations. The categories of malnourished individuals need to be differentiated. Define a baseline healthy gut microbiota for such category. Perform studies using animal systems to test the effectiveness of potential probiotics and prebiotics against these specific categories. And of course, performed well-designed human studies. So the bottom line, friends, today in this particular talk is, for the treatment of undernutrition to be effective and the response to feeding optimal, the contributions of the gut microbiome and enteropathogenic infections and consequently intestinal inflammation need to be considered. I would like to acknowledge first the Indian malnourished group who are studying the malnutrition. This is Sharmila Mande up here and Tarani Ghosh. Dr. Sharmila is here in the audience, and she did all the computational analysis. They belong to the Tata Consultancy Services and are perhaps our lifetime collaborators. I would also like to thank Dr. Abhijit Chaudhary. He was the principal investigator of the DSS project in Birbhum, who fed in the epidemiological metadata, and a great friend and collaborator. And from THSTI, it's Babatosh Das and Dr. Sengupta. Dr. Babatosh Das has now a fascinating center where there's a huge volume of work going on. I would also like to thank Nija Hajela for her inputs in the probiotic part. She's been a very valuable resource. Thank you for your kind attention.
Thank you, Dr. Nair. Would you like to come and join us? So we have about 10 minutes, Nija? Yes. Okay, so we can take a few questions. Yes.
Dr. Sethu Babu from Hyderabad. I'm a clinical gastroenterologist. Professor Nair, it's been a wonderful talk. I just want to know what is the impact of maternal malnutrition on these infants, because preemptively, if you could feed the mothers with probiotics, will it have an impact on the outcome?
Yeah, that's an interesting question, and I'll follow Dr. Conway in the sense that I'm sure it will have an impact, because there are studies which have shown even at the fetal stage, mothers being fed certain probiotics which trigger of fetal responses. So I'm sure it would help.
So now maybe I misunderstood, but see, from one of the talks I got the impression that if you have antibiotics, it disturbs gut microbiota. But you showed that for malnourished children, it has a beneficial effect. How do we sort of bring in a balance in these two observations?
Yeah, Dr. Ghosh, I didn't describe that study completely, but what happens and what the data has shown, in malnourished children, you have a unique situation where you have the proliferation of pathobionts, as they are called, like proteobacteria, which has been shown by all the studies. And one would imagine that these antibiotics target those. And once pathobionts are removed, then it's the beneficial common cells which again repopulate and amplify in numbers.
Dr. Conway, would you like to respond to the earlier question about maternal malnutrition, which Dr. Nair had?
Yes, I totally agree with your comments on that, in that it's well established now that the health of the mother will influence the infant. And there have been studies in particular in Finland where they dosed the mothers for 6 months during the pregnancy and subsequently during breastfeeding, and showed a significant reduction in atopic dermatitis in those children. And those children have been followed for now 7 years, and it has been maintained in those infants.
Dr. Ganguly?
Actually, Dr. Sethubabu, 40 years back, Dr. Gopalan fed the mothers in Hyderabad, and the outcome in children was fantastic with the control group who were not fed. And all the outcomes, disease outcomes in where the children's nutrition was maintained through mothers were good, and the others were, like Dr. Barker has said, that bad maternal environment and bad outcomes. These were hypertension, the coronary artery disease and stroke in the children. But my question is to Dr. Conway that it's very chastening thing to see that the preterm babies are maintaining bad microbial environment till 3 months after they were born. And here we need to have some policy change, because if it is not corrected, perhaps the study only went up to 3 months, but if it is not corrected, it will have a tremendous consequence at a later period. So what I am really worried about, that the pediatricians, the groups, as well as the nutrition groups should walk with these kind of findings and find solutions. The only feed which is given by Indian Academy of Pediatrics is the mother breast milk, but I think the breast milk alone might not correct these kinds of severe changes, and we need to really look at it. In India, there are 3 or 4 studies which were done in the neonatal septicemia and probiotic, and because these babies, when they had septicemia, they died. And both studies, one done by Vinod Paul and one done in Odisha, both showed the sizes were not that good, and there were some study design faults, but ultimately when handled by trained guys, there were 25% benefit in those who were given. So my question is that we need to look at that whether the science will be utilized by the pediatricians as well as the nutrition groups to cause appropriate course corrections to benefit these children.
I totally agree with your very valued comments. And in Australia, it is now common practice in the neonatal departments of hospitals for the small preterms to routinely use probiotics. And the incidence of disease in those infants has decreased dramatically. But it is a combination of nutrition and the use of probiotics. And I will flag that we're saying probiotics, but it's very important to recognise which particular probiotic strain it is. And that strains of lactobacillus and bifidobacteria can be beneficial in these infants, but not every lactobacillus or bifidobacteria out there is going to be. And that was one of the reasons I put the slide up showing which bifidobacteria can utilise mother's milk oligosaccharides, for example. So even if they're receiving breast milk, the quality of the breast milk may not be as high as the next child. If you can be supplemented with specific probiotics that can utilise those breast milk oligosaccharides. But I also will caution that there are significant safety issues, and using probiotics that are poorly defined may have poor quality control on the actual preparation could be negative, definite negative, and would be harmful to the science as a whole.
Sir, can I add to that, being a pediatrician and sitting here? I think what you're saying is very true. What we really need is, because the problem with these studies is that they are cross-sectional or case-control studies. So we don't know where the cause-effect is, unless, of course, they're randomized control studies. So we do need longitudinal studies where we have a maternal cohort followed up with a neonatal cohort to look at questions like that. Before I go to the question, Dr. Nair wants to respond.
No, I just wanted to ask a question to Dr. Conway. And it is said that mothers who breastfeed are less susceptible to long-term sequelae in terms of irritable bowel disease or breast cancer. Why would you think that? Is there a bacterial connection there?
I am aware of those comments and statements, and I think at the moment it's quite preliminary. I don't think it's supportive. But sometimes where there are smoking guns, there are fires, and the mechanism behind it, perhaps it is that the mother, it's the common mucosal immune system is trafficking beneficial cells of the immune system throughout the body. And they are then releasing the appropriate cytokines, inflammatory or anti-inflammatory. So I think it probably is involving the common mucosal immune system, but exactly how? Ask me next time I'm back.
I'm Dr. Shabda.
Ashwini?
As a pediatrician, I would like to make one comment. I'm very happy to know from Dr. Nair and Dr. Conway that some of the probiotics could help us in cases with acute malnutrition. But personal experience shows that instead we are fighting with these children earlier because of their dehydration or electrolyte changes or diarrhea. And in diarrhea, of course, we have found that instead of milk, if we put them on the curds or dahi ghol, what we call it, they do better and they recover better. And probably the specific types of probiotic might help us to achieve that malabsorption part of it, and then have good recovery of these children.
If we can have a probiotic that is down-regulating the release of the TNF-alpha into the intestine, which contributes to the fluid flow, which is responsible for the diarrhea, then it is realistic that specific probiotic strains could reduce the negative impact of the presence of that organism, which is the fluid flow associated with diarrhea.
Yes, I endorse that.
My question is to Professor Conway. I'm Ashwini Setia from Max Hospital, Delhi. If I got you correct, one of your slides showed that even the maternal gut microbiota are different in those who undergo normal vaginal delivery and those who have cesarean section. Why is it so? What explains that?
It's the It's hypothesised but has not yet been proven, but the physiological status of the vaginal delivery versus the elective caesarean is that the vaginal delivery is in itself a stress on the mother, and that the release of stress hormones within the body have a very significant impact on the microbiota. And we now know that there is, and I didn't discuss it in detail today, but there's a gut-brain axis where signals from the brain are impacting on cytokines and neurotransmitters that are reaching the gut, which in turn are impacting on the composition or metabolic activity of the microbiota, which in then turn signals back to the brain. So I believe it's the stress components, and that's why I emphasised that it was elective caesareans, not emergency caesareans, where they have gone through part of the birth process.
My question is to Professor Conway. I'm Dr. Shabnam Kaur, a specialist in functional medicine. I'm a clinician. My question was regarding that particular slide the doctor mentioned just now on the elective caesareans versus vaginal delivery versus the non-elective caesareans. Now we know that antibiotic use would influence their gut microbiota. So was there any particular arm in that study which studied women who did not get antibiotics versus the ones who got, and the incidence of all the autoimmune disease and everything in the children later on?
The antibiotic association with that study was monitored and recorded, and there was not a clear correlation between antibiotic. We know that the infants that are born to caesarean section, one of the reasons they have the delayed development of the microbiota and the reduced diversity is they frequently have a lot of antibiotic usage, but so too does the mother. And this could be a factor involved in if you're altering the microbiota from that. But those profiles were in the breast milk, and the profiles were in the breast milk in the colostrum, which is happening immediately.
Thank you.
So, okay, we'll just have time for Nirja, one question?
One last question.
Okay, one last question, yeah.
I would last...
No, I think someone who's already asked, maybe somebody from the back, please, yeah. Okay, right at the back. Yeah, please. Sorry, you'll have an opportunity to discuss it during the tea time.
Hello, I'm Gautam from Translation Health Institute. I have a question that is there a correlation between nutrition, the gut microbiome and the respiratory illnesses also? Because respiratory illnesses and the gut microbiome illnesses are the major causes of mortality in children.
I'll start with a response. 70% of the immune sampling sites are in the intestinal tract. So the changes in the, and the microbiota are triggering those immune responses that are then being transported to all mucosal sites in the body. So an alteration in the microbiota is going to affect an alteration of immune-linked diseases and susceptibility.
Okay, so I think we'll just one last line, that the data that we have is, a lot of it is from the West, and it's really time that this day we generate data here or in the subcontinent where it's going to be a very different host factor and many confounders. So I think that is something that we have to keep in mind.
I totally agree, and I'd be fascinated to see the results, the outcome.
Yeah, I completely agree.
So thank you, Professor Conway, Professor Nair, and Professor Bhatnagar.